Surgical correction. Before any surgery is performed, there is dialogue that is very important to discuss with the patient and/or caregivers. First, is the morphologic differences of ear symmetrical? Surgeon should explain to every single patient that it is rare that any otoplasty patient has ears that are exactly the same. Many patients have one ear larger or smaller than the other, or one that sits higher or lower than the other. Also, it is better to explain that if there is a discrepancy before surgery, there may likely be a small discrepancy after surgery. Finally, we have to explain that the day after surgery, when the dressing is removed, the ears will be pasted down to the side of the head and appear overcorrected. They will relax over the next several months, and revision surgery is not normally considered until the result stabilizes. Hundreds of techniques have been described for the correction of pромenoris since the inception of cosmetic otoplasty, and, though hotly debated, no single approach has become universally favored. Over the years, several surgical techniques have proven effective in the correction of prominent ears, most notably the incision suture technique described by Converse, the incision technique described by Stenstrom, and the suture technique described by Mustard. Surgical techniques for the correction of the prominent ear can be grouped into maneuvers used to create the antihelical fold, to correct the conchal defect, and to affect lobule positioning. Surgical techniques are roughly broken into three categories: sculpting, through incision or scoring of the cartilage, suturing, or combination of both methods. In addition to the various techniques available for correction of the prominent ear, several procedures are also available for fixation of the lobule, cavum reduction or cavum rotation, as previously described by Furness and more recently by Janis, Naumann and Sino. In modern otoplasty, many of these techniques are considered and concurrently utilized to match unique patient problems. Marking. It is imperative to make all markings before injecting local anesthesia, as the injections will distort the landmarks and surgical markings. First, the proposed antihelix is drawn. Next, the proposed markings for the placement of the mustard sutures are drawn. These are generally trapezoidal in nature, with the anterior arm being slightly shorter than the posterior arm. The markings should be placed roughly 7 to 8 mm on either side of the proposed crest of the newly formed antihelical fold. Next, using calipers or a ruler, the conchal bowl is measured to a depth of 8 mm from the transition line of the antihelix. This is to ensure a proper height of residual bowl remains after excision. This is generally in a kidney bean fashion. The posterior auricular incision is then marked. A common misnomer is that one needs to remove a significant amount of skin in order to facilitate setting back the ear. One only needs to extend the incision laterally enough to ensure access to preoperative markings. After the ear is marked, empiric antibiotics are started prior to skin incision. Preoperative markings using methylene blue. A 30-gauge needle, 1/2, 3/4, is passed from the external markings through the skin, cartilage, and posterior body of the ear. At this point, the needle is inserted into the tip of a 1 ml syringe filled with methylene blue. Some authors, including me, recommend this technique rather than passing a pre-inked needle from the outer surface, because the former is a much cleaner technique with less chance of smearing the markings and creating a messy field. Next, the outline of the kidney bean-shaped markings is completed in identical fashion. Planned location of cartilage resection, kidney bean, in the conchal bowl, and suture placement for antihelical fold creation. Anesthesia. Anesthetic options for otoplasties range from local anesthetic to general anesthesia. This decision is multifactorial but mainly depends on the patient's level of anxiety and personal preference. Due to the ability to obtain profound local anesthesia with nerve blocks, most of the author's patients elect for surgery with moderate to deep sedation rather than general anesthesia. Local anesthetic is key to a successful surgery. Not only does it prevent pain, but it also provides hydrodissection to facilitate access to the cartilage for manipulation and excision, if needed. General anesthesia is preferred for any child aged less than 10 years. Mature children and adults can receive sedation and regional anesthesia, 1% lidocaine with 1:100,000 epinephrine, with little discomfort. Contrary to intuition, the procedure is typically not associated with a great deal of pain, and use of Marcaine has not proven fruitful. Preoperative preparation. Prophylactic antibiotics are recommended for the majority of aesthetic and reconstructive procedures on the ear. The risk of chondritis is a sufficient indication to use an intraoperative dose of a broad-spectrum antibiotic, and to prescribe a few postoperative days' dosage of the similar agent. Step by step. The commonest procedure for otoplasty is the Mustard otoplasty, as described by Dr. Jack Mustard, Jr., in 1963. Dr. Mustard was born in Glasgow and educated at Glasgow High School and Glasgow University, and has died aged 94. He was an ophthalmologist with over a 60-year career, developed improved techniques for reconstructing eyelids, preventing eye prostheses from falling out and normalizing protruding ears, including being a prisoner of war in the Second World War. He then raised funds to build West Africa's first plastic surgery hospital, which opened in 1997, and worked there for alternate months until he was 85. Cleansing. The cleansing of the external ear is performed with povidone iodine solution. Surgical draping with any clear sticky drape keeps the hair out of the surgical field. Drapes are placed so that both ears are simultaneously on view, providing intraoperative comparison to obtain optimal symmetry. Incision. As symmetry is the key, it is recommended to begin with the more severely affected side. Incisions should ideally be placed in the postauricular sulcus, and some will excise an ellipse or dumbbell of tissue, while others feel that redundant skin is not a common issue postoperatively. The estimated skin excision on the posterior surface of the ear can be done safely with the narrowest width at the middle third to avoid telephone ear deformity. This occurs when the middle portion is reduced to a relatively greater degree than the superior helix and lobule. The incisions made on the posterior surface of the ear vary, depending on the goals of the procedure. If mustard sutures are planned, the skin incision is placed in the center of the posterior surface. If furnace sutures are taken into consideration, the skin incision is designed closer to the mastoid area. An anterior incision can allow easier access to the anterior surface of the cartilage, but does create a visible scar. To expose the auricular cartilage, different skin incisions are adopted. The standard otoplasty incision is elliptical and based just lateral to the postauricular crease. Others use dumbbell-shaped incision to minimize tension on the middle third of the auricle. Romo et al. Proposed an alternative incision that improves access and visualization and allows the surgeon to determine the amount of skin excised at the end of the procedure, rather than at the beginning, involving posteromedially based skin flap. The estimated skin excision with a diamond-shaped inferior end to correct the lower pole prominence. Modified fishtail technique is sometimes used to correct a prominent lobule. Alternatively, some surgeons who prefer to recreate an antihelix by scoring the anterior cartilage surface advocate an anterior skin incision. An anterior incision can allow easier access to the anterior surface of the cartilage, but does create a visible scar. The incision is best placed in the posterior groove of the helix and where the helix casts a shadow over the posterior of the ear. This scar is less visible when stood behind a patient, whereas scars in the center of the posterior ear or in the auriculocephalic sulcus are more visible. Technique. Surgical techniques for the correction of the prominent ear can be grouped into maneuvers used to create the antihelical fold, correct the conchal defect, and to affect lobule positioning. Creation of the antihelical fold.